Hello, my name is Paul Merrick. The topic of today's lecture is the CVP is useless, mostly, and harmful, almost always. I have no disclosures. As will be demonstrated in this lecture, the CVP is completely useless for assessing volume status. Consequently, it leads to a high CVP and iatrogenic saltwater drowning. Indeed, the use of the CVP breaks many of the basic tenets of medical ethics. The first duty is to promote good of the patient. The second, non-maleficence, the duty to do no harm. And I would contend that the use of the CVP breaks these two basic ethical tenets. These are the hemodynamic monitoring truths as articulated by Dr. Michael Pinsky, and really serves as a very good starting point when one thinks about hemodynamics. Tachycardia is never a good thing. Hypotension is always pathologic. There's no such thing as a normal cardiac output. Central venous pressure is only elevated in disease, and peripheral edema is only of cosmetic concern. Following on Dr. Pinsky's guidelines, this is my paper on the 6 guiding principles of fluid resuscitation, which include the only reason to give a patient a fluid challenge is to increase stroke volume. This is known as fluid responsiveness. We do know without any question of doubt that in hemodynamically unstable patients, those with hypotension or oliguria, only about 50% are fluid responsive. The number is likely to be less in patients who are septic. The physical examination, ultrasonography, and the CVP cannot predict fluid responsiveness. The hemodynamic response to a fluid challenge is short-lived, usually less than an hour. It's important to recognize that fluid responsiveness does not equate to the need for fluid resuscitation and fluid boluses. And strikingly important, a high CVP is a major factor compromising organ perfusion. So, what is a central venous pressure? This is from the definitive source of all medical knowledge, Wikipedia, which defines the central venous pressure as the pressure of blood in the thoracic vena cava near the right atrium of the heart. So where did this all come from? Well, this is the first paper on the central venous pressure, which was published in the Archives of Surgery of 1959 by 2 thoracic surgeons, Dr. Hughes and McGovern. What they did is they placed a peripheral central venous line, and simultaneously they measured blood pressure, heart rate, and the CVP. This is one of the hemodynamic profiles of one of their patients. You can see the heart rate and the heart rate and blood pressure remain remarkably stable, whereas the CVP fluctuates wildly with no real explanation. This was their conclusion. An attempt to correlate known methods of evaluating blood volume with right atrial pressure monitoring has been effected by the study of 25 post-operative patients undergoing thoracotomy. It has been determined that right atrial pressure is an accurate and sensitive recording of effective circulating blood volume. So this, unfortunately, is the definitive study on which the basis of central venous pressure monitoring is based. These authors did not measure these authors did not measure blood volume, nor did they perform any kind of statistical analysis. This was just an observation of 25 patients. We then move on to this study, early goal-directed therapy in the treatment of severe sepsis and septic shock. And as we know, as part of this algorithm, in both the treatment and control arm, a central venous pressure of greater than 8 was a required hemodynamic goal. This set in motion a series of events which established the central venous pressure as the prime hemodynamic goal in patients with sepsis. This was a paper I wrote to the this was a letter I wrote to the New England Journal of Medicine following publication of that paper. I knew at that time it just did not smell correct, and indeed commented that the central venous pressure was a poor indicator of intravascular volume, and the outcome of the study just made no sense. However, based on this single center study, which as we know is somewhat questionable, the central venous pressure became the prime management target in the Surviving Sepsis campaign. This is from the 2004 guideline, where we see that a target of CVP greater than 8 or greater than 12 if you're mechanically ventilated becomes the target of fluid resuscitation. We know this was then followed by the 2008, 2012, and 2016 versions of Surviving Sepsis campaign. Similar actors were involved, and the storyline did not change with the same CVP targets. So what has been the impact? The impact has been that the central venous pressure is the most commonly used monitoring tool in patients in the ICU and operating room, emergency room. This is a study by Maxime Cannison which looked at monitoring technology in patients undergoing high-risk surgery, and we can see that after measuring blood pressure, central venous pressure monitoring was the most commonly used monitoring technique. Unfortunately, humans are lemmings, and they seem to follow blindly what they're told without any kind of critical thinking. Consequently, the CVP has become pervasive across the entire world. One can even see how it has affected the standard of care. This is, as we know, the data from the ARISE study, which was looking at usual care versus early goal-directed therapy. You can see that the CVP targets and the CVP achieved were exactly the same in the control and treatment group. So indeed, this was a non-study because in the control group, clinicians targeted the same CVP, which has become part of the standard of care. However, this gets worse because, as we know, effective October 2015, the federal government in the United States mandated central venous pressure monitoring as part of the management of patients with severe sepsis and septic shock. This is from their document, the National Quality Forum, and the SEP1 guideline, which includes measurement of the CVP and measurement of mixed venous O2 to guide fluid resuscitation. Quite remarkable, as both of them have been shown to be completely useless. So what is the evidence? One has to think critically and demand to see the evidence. One cannot be lemmings and follow blindly. This was the first study to question the value of the CVP. This was published in 1975, in which they measured blood volume concomitantly with central venous pressure, and I'm sure all the statisticians can see these remarkably good correlation between these two variables. This study is even more remarkable. These were patients undergoing cardiac catheterization, in which they again simultaneously measured CVP and blood volume excess or deficit. And again, one can see the remarkable correlation between the central venous pressure and your blood volume. It was noted in 1983 the CVP has been shown to be a poor correlation with effective circulating volume, both in absolute value and trends. The CVP is thus often either insensitive or misleading. This clearly demonstrates that this concept is not new. More recently, the work of Xavier Monet and Jean-Louis Thibault, looking at fluid responsiveness as a function of CVP. Again, one can see that the CVP was just unable to predict fluid responsiveness, with a similar CVP in both responders and non-responders. Furthermore, the change in CVP does not predict change in stroke volume. Many of the holdouts, including Surviving Sepsis Campaign, believe that the change in CVP is valuable in predicting the change in stroke volume. Clearly, this is not true. This was our first meta-analysis, which we published in 2008. The question was, does central venous pressure predict fluid responsiveness? A systematic review of the literature in the tale of 7 mares. Our conclusion was, this systematic review demonstrated a very poor relationship between CVP and blood volume, as well as the inability of the CVP or change in CVP to predict the hemodynamic response to a fluid challenge. The CVP should not be used to make clinical decisions regarding fluid management. So where did the tale of 7 mares come from? Well, actually from this paper. Changes in central venous pressure and blood lactate concentration in response to acute blood loss in horses. As we are aware, this is the only paper published in the entire universe which demonstrates some relationship between blood volume and central venous pressure. This study was done in 7 healthy, standing, awake mares. Clearly, these aren't the people we see in our intensive care unit or emergency room. We then went on to do a second meta-analysis. The authors asked us why we were repeating what we'd already done before, and we responded, well, it seems like nobody understood the first time, so repetition is a good thing. So again, we repeated our meta-analysis, this time with 43 studies, which included healthy controls, ICU patients, and operating room patients. Again, about only half of the patients were fluid responders, and the area under the receiver operating curve was 0.56, which makes it a useless test, no better than flipping a coin. And it really didn't matter if you were an ICU patient or an operating room patient. Again, we concluded there's no data in any group of patients to support using the CVP to guide fluid therapy. This approach to fluid resuscitation is potentially dangerous and must be abandoned. This was the accompanying editorial by Anand Kumar, who commented, Merrick and Cavaliesi have shown that we should not be using the CVP to predict volume responsiveness or volume status. Furthermore, they raised the question about venous return and the venous return equation as promoted by Guyton and Guyton, which basically demonstrates that venous return is the difference between your mean circulating filling pressure, your CVP, and venous resistance. And that if your CVP goes up with all other factors staying the same, one will decrease venous return and cardiac output. Well, there were still people who didn't believe our data and said, well, maybe at the low end or high end, the CVP may be of some value. So this was a systematic review by Dr. Perner, in which included over 1,100 individual data sets. And again, we can see whether the CVP was less than 8, 8 to 12, or greater than 12, the CVP was useless in predicting fluid responsiveness. This is from Kaplan's Cardiac Anesthesia 2006, in which the authors make the point that there's seven flawed assumptions in assuming that the CVP predicts fluid responsiveness. Unfortunately, people now acknowledge there's no scientific evidence to support using the CVP, but they say, well, I just believe in the CVP. The same way as they believe in the tooth fairy or Santa Claus, they believe that it's their right to believe in the CVP. And unfortunately, this myth continues to be propagated by the Not Surviving Sepsis campaign. However, there are enormous dangers associated with CVP monitoring. An increased right atrial pressure will be transmitted backwards. This will increase the pressure within the hepatic capsule and splanchnic pressure. This will increase the pressure within the kidney and renal capsule, as well as increase microcirculatory pressure. This concept was elegantly demonstrated by Dr. Winton in 1931, who sought to determine the influence of venous pressure on the isolated mammalian kidney. So this was a heart-lung preparation in which he could independently alter venous and arterial pressure. And what he demonstrated is that as the venous pressure increased, the blood flow, renal blood flow, decreased to the point that it completely stopped and urine output ceased. So he found that just by increasing venous pressure had a dramatic effect on renal function. And the changes in venous pressure were significantly more pronounced than changes in arterial pressure. Move forward a few decades. This is a study which looked at the risk of renal failure in patients with sepsis, and they demonstrated that a high CVP was the only factor predictive of acute kidney injury, and that the risk of kidney injury increased linearly with increasing mean CVP. And we can see the threshold of 8, that over a CVP of 8, the risk of renal failure increases significantly. This study looked at microcirculatory flow in patients with sepsis, and again demonstrated that a high CVP was the only factor predictive of impaired microcirculatory flow. This is a study in Clinical Journal of the American Society of Nephrology, asking the question of what factors result in progression of acute kidney injury. And what they found was 3 factors were predictive: the MAP, a low MAP, and a high CVP. Obviously, the difference between MAP and CVP is organ perfusion pressure. So a low MAP and a high CVP will decrease organ perfusion pressure. Clearly, MAP is related as well to DO2. Well, what about survival? This is a post hoc analysis of the VAST study, in which Boyd and colleagues demonstrated that the highest risk of death was in patients with a CVP above 12. We need to emphasize this. The highest risk of death was in patients with a CVP above 12. And again, this is the target which is promoted and recommended and mandated by the Surviving Sepsis campaign and the federal SEP1 guidelines. Indeed, patients with the best survival had a CVP of less than 8. This again is a post hoc analysis of the FACT trial. This was patients randomized to a liberal or conservative fluid strategy. In those patients who had CVP monitoring and had a CVP of less than 8, one can see the effect of a conservative versus liberal fluid strategy on the CVP. As part of the liberal strategy, the goal was to increase the CVP to above 8. When one looks at outcome in this group of patients, the 60-day mortality was 17% in the conservative group versus 36% in the liberal group. Again, marked difference in ventilator days and ICU days. Again, clearly demonstrating the lethality of pushing fluid above a CVP of above 8. So in summary, pushing the CVP above 8 with fluids increases the risk of organ failure and death. And again, Dr. Pinsky, one of the icons of hemodynamic monitoring, has noted central venous pressure is a stopping rule, not a target of fluid resuscitation, and that if you are to do something as silly as monitoring the CVP, once it goes above 8, you need to stop. So measuring the CVP leads to fluid overload. It's really important to emphasize that a normal CVP is 0 to 4, not 8 to 12, as is promoted and suggested and recommended by Surviving Sepsis and the SEP protocol. A CVP of 0 to 4 is necessary to ensure adequate venous return and cardiac output. Clinicians seem compelled to give fluid when the CVP is less than 8. The only solution to this pervasive problem is to stop measuring the CVP. Thank you for your attention.